There have been a number of studies recently that have been looking at DOACs in the setting of people with organic valve disease and prosthetic valve disease with results that people haven't been too excited about. Okay, so it's brought up this issue of, well, what is valvular versus non-valvular heart disease, and what is the role of NOACs or DOACs? So we know that major society guidelines recommend that DOACs should be used over VKA, okay, in patients with so-called non-valvular atrial fibrillation. But what exactly is that? All right. So the reason why I ask is there have been multiple surveys now around the globe asking cardiologists and other physicians, what is non-valvular heart disease? If someone has severe aortic stenosis and goes into atrial fibrillation, is that atrial fibrillation? You'd be surprised. Only 50%, 57% of the survey participants could actually give a cogent definition. 30% knew that only mitral stenosis was included in the organic valve disease definition, along with mechanical valves. And only 13% knew that the mitral stenosis had to be moderate or severe. So because of the non-inferiority design of the pivotal DOAC versus VKA studies, the patients that were enrolled, the inclusion and exclusion criteria had to match perfectly the original VKA versus placebo trials. And in those trials, it was considered unethical to include mechanical valves and rheumatic mitral stenosis. So they were excluded from those trials, okay? And so that became the adopted definition of valvular atrial fibrillation in the guidelines, all right? They just extrapolated from the trials, all right? Now, in those pivotal studies, there were 71,000 patients, okay, if you take all the 4 trials together, and of them, approximately 13,500 had either moderate to severe mitral valve disease or prior valve surgery. And if you look more closely, the vast majority, almost 80%, had moderate to severe mitral regurgitation. 3.6 had aortic regurgitation. Only 1.7% had aortic stenosis. And 1% had prior valve repair, valve surgery, which is either repair or tissue prosthesis. Okay? So now, if we look at what was the treatment effect, okay, of NOAC versus VKA in patients with valve disease, what you see over here, I'd like you to, it's a pity this thing doesn't point, but essentially what these 2 graphs show us, first with regard to stroke and systemic embolism, is that the effect of DOAC, okay, did not interact. It was positive in all of the settings. So whether you had valve disease or no valve disease, DOACs were positive. If you look at the effect of bleeding, we see the same except for rivaroxaban. Okay, so there was a p-value for interaction for river where there was a little bit more bleeding in those on river relative to VKA in the subset of patients with significant valve disease. All right, since then, so those were the randomized control studies. Since then, they've looked at observational data taken from hospital data records in the United States, propensity matched 56,000 patients looking essentially at the same question, okay, asking in DOACs versus VKA, what's the difference? And again, you see that ischemic stroke is reduced in those on DOACs and major bleeding is reduced on DOACs. Here they didn't go and sub-specify by the type of DOAC. Okay, so if you go and look a little bit further about the multiple types of valve disease, if you've got aortic stenosis, okay, I said it only constituted 1.7% of the original cohort. AS patients, we all know, are elderly. Often they have vascular paths, and they are at high risk for both ischemic stroke and by multiple mechanisms. They are also at risk for bleeding. All right, so patients with aortic stenosis tolerate atrial fibrillation very, very poorly. It's associated with heart failure, syncope, and mortality. And the first consideration should be aortic valve replacement, as opposed to thinking about what anticoagulation you should be using. It should be a transient anticoagulation, and it should be dictated by the type of valve you replace, you put into your patient. If you look at mitral regurgitation, I've already said that 80% of the patients in the randomized trials had moderate to severe regurgitation of those with valve disease. And we know that, again, mitral regurgitation, because it blows up the left atrium, is associated with atrial fibrillation. But here, Virchow's triad doesn't apply. In fact, mitral regurgitation washes out the atrium, if you can think about it that way, and Virchow's triad doesn't apply. All right? So in this constellation of patients, again, atrial fibrillation should prompt you to think that this is a symptom of hemodynamic load, as opposed to thinking about the anticoagulation and stroke risk. If you look at mechanical valves, there have been 2 recent randomized control studies. Okay, one with dabigatran called Realign that was stopped early. It was mechanical valves in the mitral position. And then the PROACT trial has recently been stopped. It was rivaroxaban versus in the aortic position, and that was stopped early. All right? If you look at surgical tissue valves and atrial fibrillation, well, meta-analyses of small studies in this area suggest that actually DOACs are preferred. And then if you look at TAVI valves, I see lots of TAVI experts here, so I won't go there, but in a sense, there's been no strong recommendation in either direction. Okay? So if we go back to our mitral valve disease, which is what's triggered a lot of this discussion, all right, we know that INR control in rheumatic heart disease countries and regions is very poor. Efficacy and safety of VKA is very dependent on time in the therapeutic range, which is often less than 65%. So alternatives to VKA would clearly be very, very attractive for this valve. So people were hoping to find a suitable DOAC to replace VKA in patients with mitral stenosis and atrial fibrillation. And in fact, the Invictus trial, looking at rivaroxaban versus VKA, tested exactly this. It was a non-inferiority study looking to see whether this aggregate outcome of stroke, systemic embolism, mortality would be improved. Okay, and what, to everybody's surprise, in the 4,500 patient study, it was large with almost 4.5 years follow-up. Mortality, stroke, systemic embolism, MI was much better with VKA, all right? All-cause mortality on its own was the major driver of the composite outcome. Interestingly, stroke and systemic embolism were rather low in this population, but again, VKA did do a little bit better. And bleeding rates, because patients were on average well under 50 years, were actually quite low. So there was no scope for the DOACs to improve on the bleeding rate. All right? Now, what drove the deaths? Surprisingly, it was heart failure and sudden cardiac death-related mortality in the study. Okay, again, suggesting that atrial fibrillation, if you've got severe mitral stenosis, is a harbinger for heart failure and heart failure death and acute pulmonary edema. So, to summarize, compared to DOACs, VKA reduced all-cause mortality and stroke in rheumatic-associated atrial fibrillation. I've just shown you that. DOACs increase thrombosis and do not reduce bleeding in patients with mechanical valves. All right? In the setting of organic valve disease, DOACs are effective and safe and are the preferred alternative. So that's organic disease other than rheumatic. And then for TAVI valves, anticoagulation should only be used if there's a really strong indication. If patients don't have a prior anticoagulation, antiplatelet agents will work just fine. I hope I've kept the time. Thank you very much for paying attention.